Welcome to the Banega Swasth India podcast. Our focus is one health, one planet, one future. Our aim is health for all and leaving no one behind, because Swasth Bharat is Sampann Bharat. I'm Ambika Singh Kama, and today we will be talking to Dr. Rani Bang and Dr. Abhay Bang, who have dedicated their lives for the better health and upliftment of tribal and rural communities and are known for their stellar work in the rural and tribal belt of Gadchiroli, one of the most impoverished districts of India. Dr. Bang, please tell us about your journey of over 3 decades as a health reformer in the rural India.
Look, it was sheer my good fortune that I was born and brought up in and around Mahatma Gandhi's ashram in Wardha district. My father was a freedom fighter. He had worked with Mahatma Gandhi. So I was born, grew up there. I studied in a school which was started by Mahatma Gandhi in Sevagram ashram itself. I think the exposure to Gandhian philosophy and villages at that time inspired me to become a doctor with a specific purpose, how to improve health and healthcare in rural areas, rural India. That was my goal. That's why I went to medical college, studied there, went to the US to study public health further. And then on returning, my wife Rani and I, we decided to select Gadchiroli for our future work. The reason being, this was a newly carved out district in Maharashtra, carved out because of its backwardness, because it was largely inhabited by tribal population with dense forest cover, too far from Mumbai. So Gadchiroli needed healthcare more than anybody else in Maharashtra, and that's why we decided to come to Gadchiroli in 1986 and started this organization which we named Search. Really in search of health and healthcare for villages in India. That was the purpose.
Do you think the work that you have done in the rural areas on home-based neonatal care has proved to be a path breaker in the way that India and the world tackle infant mortality?
Yes, in hindsight it seems that that was a major contribution that we could make. Let's go back to 1988. For the first time we measured child mortality rate in Gadchiroli in 1988 in nearly 1 lakh population, nearly 100 villages. And we found that the infant mortality rate at that time was 121, too high. And pneumonia in children and newborn deaths, these two were the main causes of death. At that time there was no global or national program to address these two specific issues. How do you provide care to children and neonates in rural areas where Gadchiroli hardly had only few doctors and who would go and live in villages? So in search of solution, we, out of desperation and practical necessity, we thought a literate man and woman in the village is the best solution. We called them Arogya Doot, messengers of health, and we selected from each village such men and women, one per village, provided them training, skills, and this role as to if child is sick, examine, diagnose, if it is pneumonia, treat with oral antibiotic. That pneumonia treatment alone brought down infant mortality rate from 121 to 80 within 2 years. But the remaining problem was even more difficult. It was largely among the neonates. Out of 80 infants who died now, 60 died in the neonatal period, that is first 1 month. Now a newborn, not only in Gadchiroli but anywhere in rural India, is a very vulnerable, tiny, fragile human being. Its survival is difficult, and if needed, if no care is available, because there was no pediatric or neonatal hospital in the entire 300 kilometers. So I decided that probably we should train village women to become village level neonatologists. And that's how I designed this home-based newborn care in 1990, started implementing it in 1995, and Search developed a team really for implementation. we selected 39 female community health workers to work as Arogya Doot. So, the Arogya Doot, the mother, grandmother, and at that time there were dais in the villages, dai. These four kind of women became the main pillar who provided the newborn care at home. Because mothers and babies immediately after delivery were not even allowed to step out of that home delivery room, from that dark room. So, if they couldn't come out, we must go there with the medical knowledge. So, it was provided through these four pillars, but mainly through the trained community health worker. We provided for 3 years with good supervision, quality, etc. But then results were remarkable. Infant mortality rate is considered to be a very tough challenge. At that time, WHO recommendations were, if any neonate is sick, immediately refer to hospital. So, neonates were the most difficult part of infant mortality. With this approach, newborn mortality in 39 villages where we introduced reduced by 62% within 3 years and subsequently 70%. That was remarkable. And so, the Lancet immediately published this successful trial. Later on, Lancet selected this as one of the vintage papers published in 180 years of history of Lancet. We repeated it in other parts of Maharashtra with voluntary organization. The Indian Council of Medical Research replicated in 5 states. Everywhere, newborn mortality, infant mortality steeply came down. So, the Planning Commission and Government of India selected this to be expanded into the entire country. At the same time, ASHA program was developing. So, ASHAs were to some extent developed on the model of our Arogya Doot. We were asked to design a system to train 9 lakh ASHAs in India. That we did, and after 6 years of work, this became national policy and 9 lakh ASHAs were trained to provide home-based newborn care. 2 years ago, Government of India informed me that that year 1 crore 10 lakh rural neonates received home-based newborn care.
Tell us about the other programs also that you've been working on other than health for a better social environment in the rural areas.
Look, when we started talking to rural women about health, they would immediately say, Dr. Saab, please leave it aside. Tell us what to do about alcoholism of our husbands. And village after village, women persisted that we should do something to do about this alcoholism amongst men. It was not our idea really to take up the issue, but practically women forced us to take it up. In 1988, we believed that probably complete shutting down the alcohol sale in the district was the solution, taking inspiration from Mahatma Gandhi's freedom movement, during which Kasturba Gandhi and Kamala Nehru had picketed against the British alcohol shops. So, for 6 years we ran a movement against alcohol in the district. Finally, Government of Maharashtra relented and accepted our demand, and prohibition was introduced in the entire district. Prohibition alone reduced alcohol consumption and supply availability by nearly 40%. But still there was remaining problem, illicit alcohol and tobacco mix called khara had increasingly become popular. So, 6 years ago we conceived another idea that not only alcohol but now alcohol and tobacco, both the problems need to be addressed. By that time globally, alcohol and tobacco had become 2 of the top 7 causes of death, disability and global burden of disease. So, it was very consistent with the global public health priorities. So, we designed an approach called Muktipath, in which Search, Government of Maharashtra, Tata Trust at that time and now Rohini Nilekani Foundation now, and people of Gadchiroli. So, 4 partners together will try to reduce both demand as well as supply of alcohol and tobacco. We have used 4 main strategies. One is to make people aware through education that how harmful these substances are. Through district sample survey, we estimated that people out of their pocket were spending 393 crore rupees every year on this, purchasing these two substances. In addition to the harm to health, men who were drunk didn't work, so productivity loss. Men bet women at home and publicly, so women became insecure. So apart from several other costs, in monetary term, people were spending nearly 400 crore rupees on these two items, which was twice the district development budget of government of Maharashtra. So make people aware about this. Secondly, the prohibition which was already introduced by the state government, make it more effective by cooperating with police and government, district administration. But most important, organize in each village women's group and the village Gram Sabha against illicit alcohol and tobacco. And that has been our most powerful strategy. In 1500 villages, out of 1500 villages, now we have in 1300 villages such village organizations who act as a watchdog to reduce the illicit alcohol and tobacco. In 5 years, and the fourth strategy is de-addiction therapy in villages at the taluka places. We have so far treated 10,000 alcohol addicts. There are village based organizations in 1300 villages, and net effect, the total alcohol and tobacco consumption in the district is reduced further by 30%, saving 80 crore rupees per year to the people of Gadchiroli.
As we've been talking about how only a healthy India can be a prosperous India and leaving no one behind, please tell us, why is tribal health so important, and are we really keeping them in mind while setting health goals?
If you ask any educated person in India, how many tribal people live in India, they won't know. 104 million tribal people live in India, and more than half of them live in remote areas, forests, jungles, hills in the northeast. Now, Government of India had appointed an expert committee, national expert committee under my chairmanship. After 5 years of work, we produced a report. It's the first report after independence, Tribal Health in India. So we found that the health status of tribal people was worst as compared to any other social section in India, and major disease killers and major gaps were identified. There was huge funding budget, government funding deficit to tribal health. Human resource was not available. So we have made several solutions, we have recommended several solutions to bridge this gap, so that to bring the health status of tribal people anywhere in India at par with the non-tribal population of the same state within 10 years. We have recommended by 2027. We recommended it in 2018, now it is 2022. We wish that the goal should be achieved by 2027 if Government of India and state governments act on it.
Please tell us about how you helped develop care-seeking behavior among the tribal communities.
We came to live in this tribal block of Hanora in 1992. So, how to provide care? So, we thought of naturally hospital. We collected tribal people from 50 villages and we asked them, what sort of hospital would you like to have? Why don't you go to government hospitals? They said, we are afraid. We are afraid of big buildings. We are afraid of white coats. We are afraid of the language that they speak there. They laugh at us. So, we realized that if we want tribal people to seek care, not feel shy, not feel afraid, we need to build a tribal friendly hospital. So, taking inspiration from Mahatma Gandhi's Sevagram Ashram, we constructed here our first tribal friendly hospital of huts, which looked like a tribal village, didn't look like a hospital. And to again make tribal people feel safe and secure, we created a temple of their goddess. Their goddess is Danteshwari, and that is why this hospital was labelled by tribal people as Ma Danteshwari Davakhana. It had a unique design. Its origin and generation itself was through consultation with the tribal people. So, it became a sort of a collaborative partnership between tribal people and us.
What can we learn from the tribal communities and replicate in our lives?
We consider tribal people backward, almost savage. But first thing we should realize is that genetically tribal people and we non-tribal people are practically the same. They are not genetically inferior. They are as good, as intelligent or better than us. Look, the tribal sports women, they are making a lot of records on behalf of India. Not only physically they are same as we are, but socially and culturally I would say they are far superior to us. Tribal people live in harmony with the nature. They don't destroy forest, they don't destroy nature, but they live with it in harmony. When the global warming is happening, this is the first thing we need to learn from tribal. How to reduce your consumption, your need, your carbon footprint and live in the harmony with the nature. Second thing is, tribal people live in a communitarian way and with lot of sharing of food, material, practices and life. While in most of the urban societies, people live in apartments, lonely life, stressful, competitive life, everybody is so tense as compared to that tribal life in a tribal village. Though on physical ground they may not have many amenities, but their life is much more happy as far as the community is concerned. Tribal women, in some sense, they are freer than the average middle class woman in India. A tribal girl is allowed to marry with a boy or man she wants to marry. She has that freedom. In tribal societies, you practically never hear about rape committed by a tribal man on woman. If at all rapes are committed, they are by non-tribal coming from outside. So, tribal women have, in some sense, she can divorce husband if she wants. So, tribal women have a lot of more freedom than we have. And lastly, Constitutional Amendment of PESA, as it is called, has given tribal Gram Sabhas rights for grassroots democracy. This is almost revolutionary. If it is really implemented in practice, tribal Gram Sabhas and tribal grassroots democracy would be far better than in the rest of the places.
Dr. Rani Bang, please tell us, from Johns Hopkins in USA to Gadchiroli, was it a difficult decision to make?
Of course, it was not an easy decision, but our purpose was to serve the most underprivileged and disadvantaged people, and that way Gadchiroli was separated from Chandrapur in 1982 and we came back in 1985. So we thought that whatever we have learnt in our medical curriculum and at Hopkins, we should make use of it in this area where there are no other health services like clinical services, other services. You won't believe, but I did the first cesarean section in this district. Nothing was being done that time, and it was a bold decision, but we were both determined and it was a voluntary choice. And when we look back, we think that it was the wisest decision we have taken in our life. And we are really honored. So many people here, they give us chance to serve them. It's a great honor for us.
What was your experience back then of the main health concerns faced by women in these areas?
I am a gynecologist, and in my experience I always felt that the whole maternal and child health program of Government of India was focusing on family planning. Of course, I am not against family planning, but family planning should be for the better health of women and children. And India's family planning program was population control oriented, target oriented approach. So people never felt that it was their need. And maternity care was equated only to antenatal care, giving 2 shots of tetanus toxoid and doling out iron calcium tablets. But in my experience as a gynecologist, I found that from menarche to menopause and even thereafter, women have so many gynecological problems like menstrual problems, sexual problems. They have got reproductive tract infections, what we call white discharge. They have pain in abdomen, pain in back, and they have breast problems. All these problems are there. And when I did a computerized literature search in Washington, which is supposed to be the National Library of Medicine in Washington, which is supposed to be the biggest library in the world, I found that there was not a single study to show what was the prevalence of these gynecological morbidities at the community level. And so I decided to work on that. And when I presented this thought, many people just ridiculed me and they said, what is there in gynecological problems? White discharge is an innocuous symptom like nasal discharge. But when we came to Gadchiroli, I talked to 100 key informants and I asked them to write down 1, 2, 3, 4, 5, 6, right? They could not write, but tell me what are the common problems. And number one problem was white discharge. And then whatever 10, 12 problems they told me, I asked them to divide it into 3 categories: mild, moderate and serious type of disease. And to my surprise, I found that 100% of the women put obstructed labor and infertility in the most serious disease category. In obstructed labor, of course, there is a chance of death and we consider it as serious problem. But infertility, there is no death. So I asked those rural women and tribal women, why did you put these two together? And these women gave me such a wonderful reply. They said, Madam, if there is obstructed labor, that lady dies only once in her lifetime. But if there is infertility, she dies daily. Because everybody blames her for her infertility problem. Nobody thinks that husband is at fault. And so whatever my conviction was there, it was strengthened. And then women said that government is only interested in cutting our tubes to make us infertile, but already those who are infertile, there is no treatment available for them. So I did the first community-based study of gynecological problems in rural area in Gadchiroli. That study was published in Lancet. It's supposed to be the first study of its kind in the whole world. And I showed that 92% of the women had gynecological problems and only 8% of the women had ever sought any care for gynecological problems. 50% of the women had reproductive tract infections. Nearly 37% of women had menstrual problems. They had sexual problems, sexually transmitted disease. And then nearly 50% of the unmarried girls had premarital sex, which was, I was not surprised because I see it daily in my OPD, but that was a big surprise for others, and it was in rural area, not in tribal area. And then it was published in Lancet and it drew a lot of attention from different international agencies, women's groups. I was called to WHO for World Health Assembly and I presented this study there. And in 1996 again there was a Cairo conference and the total policy in the world changed. Previously they used to call it maternal and child health, and I coined the word reproductive health and child health. So that word was coined by me. WHO started special division, ICMR, Indian Council of Medical Research started special division, and the policy all over the world changed because of this first gynec study. And then I trained the traditional birth attendants to treat the gynecological problems at the community level because there were no gynecologists and there was no transport, no communication, and we couldn't expect women to come to gynecologist. I was the only one.
Why is it important to focus on women's reproductive health?
Because one thing is, if there is no proper maternity care, she may die, and if she is malnourished, then it influences the child's growth. So undernourished children are born. Then secondly, there are stillbirths, there are neonatal mortality in children, childhood mortalities because of infection. So we have to definitely focus on maternity care, both antepartum, intrapartum and postpartum care also, because postpartum infections, postpartum bleeding, postpartum mental disorders are very common in rural area and urban area. Nobody thinks about it. So we have to focus both on the mortality aspect and the morbidity. Unless the quality of life is good for rural women, because they have to bear the triple burden of earning for the family, then doing all the household work, and then producing children and taking care of the children. So their quality of life should be good. So I thought that not only maternity care, but we should focus on other aspects of reproductive health.
What about girls? because in our country, unfortunately, still boys are given priority. How can we break the bias and give equal access to health to our girls?
Actually, there is a vicious circle in India. The mothers are malnourished, they get married at a very young age, not properly taken care of, and after delivery they give birth to the malnourished baby, and because her nutrition is very poor, and in the family also more food is given to the boys, less food to the girls. So they grow up as malnourished adolescents and then they get married. So again they become malnourished mothers and they give birth to the malnourished children. So this cycle goes on and we have to break it somewhere. So I think that we should start from the girls, because unless we improve the status of the girls, the mother's status would not improve and newborn and child mortality will not come down. So girls are very important, and in India there are so many, like girls are getting now education. We are talking about equal rights for men and women. But unless the girls or women take care of themselves, nothing is going to change. So I think we should focus on empowerment of the girls. That is very, very important. And not only the girls, I would say, that we should also focus on boys. We always talk about responsible motherhood, but we should be talking about responsible fatherhood, because in olden days mothers were only sitting at home cooking, looking after children, but now the time has changed. Girls have already entered 21st century and boys are still in 20th century. So responsible parenthood includes both motherhood and fatherhood. So we should sensitize boys for becoming good fathers to take care of their wives and children.
Please tell us how important it is to talk about menstruation and menopause in rural areas.
Actually, there are so many superstitions and taboos attached to menstruation, both in rural, tribal area and also in urban area. I was attracted to Korma problem because I remember when we came to Gadchiroli, about 8 kilometers from our place, one recently married 18 years old girl, she died in Korma because of snake bite, and nobody touched her, nobody brought her to the hospital, and she died there only. So I started talking to people about the physiology of menstruation, and there is no need to keep the girls or women separate out of the house. And when I talked to women, women told me, no madam, we want this Korma. And then they told me that it's mostly seen in tribal culture. They said that we want to go and live in Korma, because in tribal culture, women have to do all the physical work, all the household work, taking care of the cattle, animals and children, and also in the field. They do the plowing. In most of the other areas, men do the plowing. Here in tribal areas, the women do that. Then they said that at least this 4-5 days we will get some rest. Then they said that sex is a must in our culture every day, and so we want to escape from it. So this is a good escape place for us. Then they said that we are so busy otherwise in our household chores, we never get time to talk to other women, do gossiping, and we don't get time to move around here and there in the forest, go to the streams. So they said that we want Korma. And then I talked to people in many villages, held Gram Sabhas, and told them that the Korma, condition of Korma was very bad, and it was unprotected, and I asked them to construct Kormas with their Shramadan. So in some villages, men and women came together and they constructed Kormas. But recently, since last 2 years, Mukul Madhav Foundation and Kherwadi, we have got collaboration with them, and Mukul Madhav Foundation gives the money, Kherwadi people, they construct the Kormas, and we mobilize the people because they need to have Shramadan in that, and there should be a demand from the people. So because we have so much contact in the village and all that, so we 3 organizations have come together, and the Kormas are getting constructed in different villages. They are wonderful buildings, women very much like it. They themselves contribute to the construction of Korma, and Mukul Madhav Foundation is also trying to help them in earning the livelihood, giving them tailoring machines and all that. We emphasize on health education of women in Korma and other women outside Korma, and we give them sanitary napkins which are not plastic one but disposable, biodegradable sanitary napkins.
Tell us about the books you have written.
Two books I will definitely say. One is Canosa, because in my experience I found that we are trained in Western medicine, and here people have very different language. They have their own perceptions about the body anatomy, body physiology, body pathology, which we are never taught in our medical curriculum. And when we work with people, we say that we have to educate them, but first of all we have to educate ourselves how to educate them. And so we have to know what are their perceptions about different diseases, what are their reasons and barriers for seeking particular type of care. So I did a study talking to men and women regarding different aspects of reproductive health problems. So that book has been published as Canosa, means someone is whispering in your ears and telling you something about their very, very private parts and private body functions and all that. The second book is Goin. Goin means a friend. It's a tribal Gundi word. And I was training the traditional birth attendants in treating women's health problems, and I told them that it should not be one-way process. I will teach you something, in exchange you have to teach me something. And because I am very much interested in trees and all that, and this area is all under forest, so I asked them to teach me about the trees. And in one of the meetings, one TBA told me that this particular plant is used to kill the husband. And I was surprised. I said, why to kill the husband? They said, if he is involved with someone, or if I am involved with someone, or if he is abusing me, to get rid of him we can use this plant. And immediately other women started telling me recipes, quoting instances where women have killed their husbands. So I got interested into that these women have been living in the forest since ages, and they have a very separate relationship with the trees. So for next 2 years I devoted my time to this, and all the relations which matter, which are very important for women, like brother-sister relationship, husband-wife, lovers relationship, mother-daughter, father-in-law, daughter-in-law, mother-in-law, daughter-in-law, two sister-in-laws, all these relations are described in terms of, there are multiple songs, there are many folklores, there are stories, and it has got environmental effect also, because these particular trees have protected women and from abuse, or they have given nutrition to her. So this tree should not be cut. So it's a very different type of information I got, and I did that study only out of my interest. I am not a trained botanist or anthropologist.
Dr. Rani, please tell us a bit about your learning from the tribal communities.
I think I have learnt a lot from tribals. Initially I had a very tunnel vision, tubular vision. Maybe I was a good gynecologist, but all this wisdom I have learned from them. And when I look at tribals, I always wonder who is more civilized. We say they are illiterate, they are ignorant, they are superstitious. In tribal culture, there is no dowry, and so there is no dowry death. On the contrary, the girl has to be given dowry from the boy's side. In tribal culture, you will never see a beggar. In tribal culture, there is no theft at all. Nobody locks the houses. All the villagers are in the forest for the whole day. In tribal culture, there is a community decision making, and if there is any problem in the village, they will sit together for 2-3 days, and there is unanimous decision making. In tribal culture, in the daytime they are always in the forest, but in the evening when they eat, they will always inquire whether my neighbor has enough food or not, and whatever they have, they share it with others. There is no sexual abuse, no sexual violence against women in tribal culture. This rape and all that is not seen in tribal culture. So now you tell me who is more civilized, they or us? So we have to learn so many things. Just because people are illiterate doesn't mean they are not wise. So wisdom and education, they are entirely different things. And in my experience, I found that most educated people sometimes could be most foolish, and these illiterate people could be very wise. They have learned from their own life and
Thank you so much, Dr. Rani and Dr. Abhay Bang, for joining us today. That's it on the Banega Swasth India podcast this week. If you have comments, queries, or suggestions on the topic we discussed today, or issues that you would like us to cover in future, do write to us on bsipodcast@ndtv.com. Remember, BSI stands for Banega Swasth India. You can also connect with us on Banega Swasth India handles on Facebook, Twitter, and Instagram, and continue the conversation through the week. Till next week, this is Ambika Singh Kama signing off. Stay healthy,